Hey guys, Dr. Ash back with newborn care and consideration. So this will kind of like wrap up the maternal health sort of content that we've been working on because it relates to newborn care, and that's the reason why it's grouped under here. And so newborn care and considerations, again, this is going to be just the down and dirty basic information that you need to pass tests, to pass NCLEX, things that we just don't go a whole lot of detail into because it's kind of basic common sense. So let's go ahead and get started. Maybe. There we go. So initial newborn care. So as soon as the baby comes out, one of the first things that we do as the provider is suction the mouth before the nose. And the way I remember this is in the alphabet, N or M comes before N. So mouth before nose. We want to assess respiration. Some very classic signs that the baby is having issues with respirations or respiratory distress would be nasal flaring, grunting, retractions, and that seesaw or uneven breathing. The reason why I assess respirations is high, the ABCs, we talk about that, but also because remember when that baby comes out, when it's delivered, there's that transition from fetal circulation to newborn circulation. Okay, and if you need like a revisit on that, I would go back to antepartum. Then what we do is we do APGAR scores, and APGAR scores tell us how well the baby is adjusting to extrauterine or life outside of the uterus. That's all extrauterine means. So adjustment to that life outside of the uterus. APGAR scores are performed at 1 minute and 5 minutes after birth. Again, that fetal circulation transitioning over to newborn circulation is the primary reason for that. Remember, there are a lot of changes that start to happen with that first breath. APGAR scores typically look at activity, breathing effort, heart rate, color of the baby, just different types of things. And no one is ever going to ask you, I don't think, at least, not unless you're working in this world of newborns, but nobody really asks you the details of APGAR scores. So just have an understanding that it's an adjustment to extrauterine life. A score of 8 to 10 is really considered perfect. No interventions are really needed. If you have a little bit lower of a score, like a 6 or a 7, it's not uncommon to have a repeat APGAR score at like 1 minute, 5 minutes, and 10 minutes. So very common, like the lower the score, the more interventions are needed and the more likely you are to have to do more than one APGAR. The next kind of thing I want to talk about are phases of newborn instability. And basically, this is like a transition. Again, when this baby first comes out, this is called the first period of reactivity. It's within the first 30 minutes to an hour after birth. This baby is alert, they're active, they're engaged, they're exploratory, they're like finding food source, and they're kind of taking in their initial environment. Then that is followed by a period of decreased responsiveness. And this is not a bad thing. This is actually an expected thing. This is anywhere from that 30-minute to 3-hour mark. And typically the baby just sleeps. So it's shocking to go from like the inside warm, happy, quiet place to the bright outside world. And so after that reactivity, they kind of have a crash where it's decreased activity. They're typically asleep. They might do some twitching or some dreaming, or they might startle themselves. But in reality, the vital signs kind of slow down and the baby's like kind of taking a deep breath, like, okay, this is my life now. And then that's followed by the second period of reactivity. And that's about 4 to 6 hours after birth. This baby is awake. They're hungry. They're cranky. They begin to produce stool and urine and mucus and all the things baby related. So the second period of reactivity is really kind of the wake up period. I'm here, I'm ready to go, let's do this thing. A little bit about skin. So there's a couple of variations in regards to skin. When the baby is first born, usually our Caucasian or our lighter skin ethnicities tend to have a pinkish red baby. So that baby comes out pink with some undertones of red. In our darker skin populations, that baby comes out pinkish brown. And even in some of the darker populations, the baby actually doesn't gain its pigment until a couple of days later. So just be aware that just because the baby comes out a little light doesn't mean that that's the end color that this baby is going to have. What also is a normal variation is something called acrocyanosis. This is bluish hands and feet, and we're looking at extremities. So this is basically normal. Again, that pediatric or that fetal to newborn circulation, it takes time to perfuse the hands and feet, right? They're not the most important. The important thing about acrocyanosis is that the baby has centralized pinkness. And what I mean by that, the abdomen, the chest, the head, those are all pink because those are the vital organs. That's where the heart, lungs, brain happen to be, liver, kidneys, stomach, etc. So acrocyanosis, completely normal, usually goes away in the first couple of hours, but it can last up to 10 days, should not last beyond 10 days. That's indicative of a heart problem. A couple other variations here, and I'm gonna go ahead and tell you, I'm gonna butcher this first one, but telangiectasis nevi, or stork bites. This happens to be just like red striation or red marks on the face, head, neck, and maybe upper shoulders. This is just a normal kind of thing that happens during birth, and they will typically go away. Nevus flammaris is a port wine stain. Basically, that is a type of hemangioma, again, in the head and neck region, will typically go away in the first couple of years. And then we have nevus vasculosis, which is kind of a strawberry type hemangioma, which will also go away. The last kind of variation that I want to talk about, and it's because it gets misinterpreted a lot, are Mongolian spots. So Mongolian spots actually are a common occurrence in our Asian and darker tone or darker skin populations. They show up as a bluish gray color on the lower back and buttock region, which also happens to show up or look like bruising. So oftentimes Mongolian spots can get misinterpreted for child abuse. So just recognize that Mongolian spots are normal. Let's move on to the cardiovascular system. Kind of our top things that we want to do for this baby is keep them warm. We're actually going to talk about thermoregulation here in just a minute. Apical heart rate for a full minute, because again, that circulation, that fetal circulation to newborn circulation is often changing. And so we really want to listen to that heart for a good minute. We're assessing for murmurs, extra sounds, and we're going to follow up on that assessment because guess what? Some of those things can go away as the fetal circulation resolves. We're going to check for pulses, and then of course we're going to assess for cyanosis and acrocyanosis, acro being just the hands and feet, cyanosis being full on blue. So we got to be careful about that. In the respiratory section, we've already talked about suctioning mouth before nose, in before in, so that's high priority. Anytime you suction that baby in the first several months, we're going to go mouth before nose. Observe for any distress. Remember those retractions, the grunting, the nasal flaring. Observe for any signs of hypoxia, and they may require just a little bit of blow-by oxygen. Again, based on their APGAR scores, it may be just a tiny little bit of oxygen in order for them to adjust to extrauterine life, or it could be more long-term. But anyways, we're just talking about normal right now. The liver comes out pretty immature, and we have something called physiologic jaundice. Physiologic jaundice happens after 24 hours. So this baby is like 2 days old. Gets a little yellow. This peaks at about day 5. So day 1 to day 5 is really when our aha for the jaundice is going to happen. We do encourage early feeding in order to stimulate the gut to start working and producing and the liver to start doing its thing. Of course, we want to keep the baby warm. Cold stress is a real thing. Again, we're going to talk about that. And then vitamin K is administered shortly after birth. This is to help with clotting, because remember, your liver, when it's dysfunctional, immature, not operating like it's supposed to, people are at high risk for bleeding. And so these babies are as well. And so we give that vitamin K because they haven't had any vitamin K for nutrients yet. Now, the other piece to this is pathological jaundice. So that means there's something wrong. But again, we're primarily focusing on normal. So that's why I talk about physiological jaundice. Pathological jaundice, that baby comes out yellow. That's a problem. So any sort of yellowing or jaundice in the first 24 hours, that's the problem. Anything after the first 24 hours, we expect to a certain extent, and we would follow that for hyperbilirubinemia. But again, we're talking normals here. Kidneys. Kidneys are rather immature. They've not had to do a whole lot of work, okay? So they are unable to concentrate urine. They're immature and unable to concentrate urine. And so what's going to happen is they're going to have a fluid volume loss. And that water loss accounts for about 5 to 10% of the total body weight in the first couple of days. Typically, that weight is regained by their first prenatal visit, or not prenatal, I'm sorry, first newborn visit with their pediatrician. We do encourage daily weights, I's and O's. We typically weigh diapers for output. And of course, assess signs for dehydration, that anterior fontanelle, if it's sunken, if the eyes are a little sunken, if they're not voiding, if they don't have tears when they cry. Those are all kind of baby assessments for dehydration. So umbilical cord care, the umbilical cord has to stay clean and dry. It should not be submerged in water. It should not be have soap routed all over it, nothing like that. So clean and dry. We typically fold the top of the diaper down just so the cord does not rub against it, because we don't want that cord to prematurely fall off. That cord is going to fall off by itself anywhere from day 7 to day 10. We don't pull it, we don't force it. It's one of those things that has to dry up and close on its own. Until that time, how do we keep this baby clean? We're going to sponge bath. So sponge bath, sponge bath, sponge bath until this cord falls off. And we're going to talk about bathing here in just a second. If you have a male gender baby, circumcision care, typically once the circumcision happens, a petroleum jelly gauze will be placed on the end of the penis. It may be just Vaseline. I've seen different facilities do a little bit different. Unless it's a Plastibell, that is a very specific type of circumcision. Again, we're not going to go into that because the general care stays the same. Once that baby voids after having the circumcision, then we remove the gauze. The penis has to be cleaned after each void. We typically take a rag, because again, we can't submerge them in water, right? We have a fresh surgical site in the penis area. So we will actually squeeze warm water over the area to help clean it. There is sort of a milky covering called yellow exudate that should not be removed. I equate that to like a scab. So when you fall down and you get a cut or an abrasion and you form that scab, what happens when you pick that scab off? It starts to form a scar tissue. And so the same thing is going to happen at the end of this poor baby's penis if you take off that yellow exudate. So the yellow exudate must stay. The biggest thing after a circumcision, we've had trauma to the penis and potentially the urethra. So we have to watch for urinary retention. So urinary retention is a big thing. The GI system, again, very immature. It can digest simple carbohydrates, but it cannot break down certain proteins. That stomach is relatively small. From the nursing perspective, we're either going to assist with breast or bottle feeding. I would like to tell you that breastfeeding is easy and natural, but sometimes it is a challenge for some women. We want to make sure that we burp them frequently during and after feedings. Number one, because we do have that small stomach size and we don't want projectile vomit happening. And number two, a gas is really painful to a baby. So we want to make sure we get good burps after feeds, or they can be rather cranky. And you're standing around like, why is this baby still crying? I don't know. Probably has some gas. The other thing you're going to do is assess for stool patterns. There are 3 kind of specific stools that you're going to see in the newborn phase. The first one is the meconium, and that's really like a black, thick, sticky, tarry substance that just kind of sticks to everything, really kind of gross. And that's kind of a combination of all the waste that has built up during the development of the baby. Transitional is really going to be like a yellowy mustard kind of color, and then it's going to turn seedy, and it literally looks like strawberry seeds in like a greenish yellow stool. And then in a couple of days, that's all going to go away, and we're going to have normal bowel movements. Now, I will tell you, a breastfed baby tends to produce stool that looks similar to whatever the mother ate. So just don't be surprised if you need to tell about that. All right, thermoregulation. So this is the regulatory of the heating system. So again, just like everything else, it's really immature. It hasn't had to do anything. The amniotic fluid has really been the warmer for a while. And so what you need to understand is we shiver, right? When we're in the cold, we start shaking and shivering, and that produces heat. Well, newborns can't do that. Newborns don't have the ability to shiver. What they do have is called brown fat or brown adipose deposits, and those deposits actually help to transmit heat throughout the body. So brown fat deposits are where the baby gets their heat. Now, the baby loses heat through several different ways, and this is important to understand. So evaporation would be heat loss because there's water on the skin. So that's why we dry the baby immediately after birth. We dry immediately after a bath because we don't want them to lose heat through evaporation. Heat loss through radiation is being around cold objects. So the cold radiates through the skin of the newborn. Convection would be like if the mother is running hot and she's got the fan on high and the baby's just laying there in a diaper, like that's no bueno. So convection heat loss from drafts and fans. Conduction heat loss would be placing them on a cold surface, and we don't really want to do that. And the reason why we don't want to do that is because they go through something called cold stress. And this is really where oxygen and energy demands get so high that the baby can't focus on the essential processes of the body. So it can't regulate blood pressure. It can't function with the heart rate. The respiratory rate messes all up. Metabolism gets off schedule. So really cold stress, very, very important that we keep these babies in a warm, closed environment. A couple of different reflexes that you're going to see, and I didn't go into all of them because these are kind of our big ones. The sucking and rooting reflex, again, anything that strokes the cheek of the baby, they're going to turn looking for a food source. Of course, swallowing, they have to coordinate their suck swallow reflex. Palmar plantar grasp, that just means when you put a finger in the palm of the baby, they close their hand around it, and it's the cutest little thing ever. The Moro and startle reflex have different outcomes, but they basically assess the same thing. And that's if you make a loud noise by the baby, they will actually jump. That's that startle reflex. And lastly is the Babinski's, one of my favorite because I love saying the word Babinski because it's just a fun word. But that is neurological, and it's stroking the bottom of the foot. So we do a firm stroke on the bottom of the sole of the foot, and there should be some toe extension, fun kinds of things. That reflex actually goes away at about 1 year of age. And if it's negative, that could be a neurological problem with the baby. So some teaching, we love to teach in nursing. It's just what we do. Formula, we need to make sure that the water is sterilized. We don't heat in the microwave because the bottle gets hot spots. And while the initial dab of the bottle feels appropriate for the baby, there could be some scalding areas within the milk. So you have to be careful of that. And just know that, and this is both for breast and formula feeding, that is enough food for the first 4 to 6 months of life. You really don't need to start introducing solid foods until we get to about that 4 to 6 month age range. Breastfeeding, again, we're going to teach pumping and storage of the milk, support for the mother, because again, even though it's a natural thing, not so natural for some women, so it may need some extra support. Bathing, we want to be in a warm room using mild soap, nothing scented, nothing heavy, nothing that'll break their little fragile skin out. And we got to make sure we clean the folds. Babies have lots of folds: neck, underarms, growing, scrotum, labia. We just have to clean all those little folds. Clothing, newborns' head should be covered. That's their primary way they lose heat, is through their head. And of course, we want to layer clothing because we can take off if they're too warm, add on if they are too cold. So let's talk about the couple of different variations here. We have the preterm infant and the post-term. Preterm, it happens after 20 weeks, but before 37 weeks, just remember every single body system is immature. Heart rate, GI system, the skin, the immunity function, hematological functions, all very immature. Vital signs are usually every 2 to 4 hours of airway, breathing, and circulation. They may require oxygen, although we don't want to give too much oxygen because we can actually cause a bleed in the brain if we over-oxygenate. Intake and output, electrolyte, daily weights. One of the things with preterm infants is their sucking and swallowing reflex may be very immature. Remember, if they're premature, they weren't ready to come out yet. So that suck and swallow reflex may be gone. or it may be very immature. And so breastfeeding, they would tire easily. And a common question that we get is, why would we give them a bottle over a breast, or how is bottle less energy consuming than breastfeeding? The answer is this: breastfeeding takes work. It takes a lot of work. They have to really give a good suck to stimulate the milk to come down, and then they have to swallow. So it takes a lot of effort to breastfeed. Bottles, on the other hand, and you can purchase one and try this. You can just go to the $1.25 tree and practice this. But the holes within the nipple of the bottles are much larger. So if you fill it up with a liquid and you turn that bottle upside down, it will drip whether or not somebody is sucking or not. Okay. And so the flow through a bottle is much faster than it is through breastfeeding. So they don't have to have as much effort. Again, warming devices, they're usually in a radiant warmer or an incubator, depending on how early they are. And of course, protection from infection, super important because their little immune systems are not ready for the germs of the world. The postterm infant, this is going to be a baby after 42 weeks. They typically have issues with glucose control. So we have to worry about hypoglycemia, again, temperature regulation issues, and meconium staining. So believe it or not, if a baby is late or stressed out in utero, they tend to have a bowel movement in the womb. So sometimes babies will come out with kind of a greenish or blackish discoloration of their skin, fingernails, toenails, everywhere, that sometimes can come off during the bath, but not always. So just be aware that meconium aspiration and meconium staining are real. So the last thing I want to talk about here are vaccinations. And I'm only putting it here because we do start vaccinations in the hospital. So understanding that vaccines are a form of primary prevention, that's the first thing we need to talk about. So form of primary prevention. Hepatitis B gets started before they leave the hospital. So Hep B injection is given before they leave the hospital. The biggest thing we want to assess for is allergic reactions, either physical or neurological. They may have seizures after immunization. Those are all things we want to watch very closely for. One of the common things that I hear parents say all the time is, ouch, that immunization hurts, or I don't want to give them immunization because it's going to be painful. So we have something called a topical anesthetic. It's called EMLA cream, EMLA, basically epinephrine, I forgot the M, lidocaine, and some sort of anesthetic, but it's a topical that we can put on so the baby actually doesn't feel the needle going into the skin. The typical needle size for a newborn immunization is going to be a 25 gauge, 5/8 of an inch. So 25 gauge, 5/8 of an inch. If we have a little bit of an older baby and we want to prevent kind of that local redness, swelling, any of those kinds of things that typically happen, like normal vaccine reactions, we can use just a little bit of a larger needle, usually a 1-inch. We typically use the vastus lateralis muscle, which is the most common in babies and small children, but we want to avoid the dorsogluteal. So dorsogluteal would be the only muscle that's technically contraindicated for immunizations. All right, guys, and that's all I have. I hope you found it helpful. Make sure you comment, like, and share, and subscribe to the channel, and I will see you guys in the next episode.